Welcome everyone to today's webinar. I am Brooke Murphy, Content Strategist and Editor with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. This webinar is sponsored by GE Healthcare and Intel, working together to advance innovation and care efficiency through industry thought leadership. At this time, it is now my pleasure to start today's webinar by introducing our esteemed presenters. Dr. Jill Larkin is the Senior Director of Strategic Initiatives for the Center of Nursing Excellence at UPMC. Using her 32 years of experience, that includes Executive Director of Quality and Clinical Director of Professional Practice, she leads the Nursing Career Ladder Strategies, Shared Leadership Councils, and Workforce Management. Driving various nursing transformation for the UPMC enterprise is essential to nurse and patient engagement and quality outcomes. In addition, Joe was a past Baldrige examiner and currently active in the American Society for Quality Pittsburgh chapter and is a board member for the Southwestern Pennsylvania of Nurse Leaders. Lorraine Brock, MSN RN, is the Director of Workforce Management at UPMC. She has 35 plus years of diverse experience as a bedside nurse, as an in- and outpatient cardiopulmonary coordinator, and as a magnet coordinator, as well as in various roles for nursing recruitment within HR at the corporate level. Her current role as Director of Workforce Management focuses on leading the rolling implementation of scheduling software across the UPMC enterprise system. Her work includes ongoing collaboration with ISD and the software vendor for the technology aspects while managing the operational implementation of the software. Bill Christie is a Senior Services Director of Workforce Management Solutions at GE Healthcare Digital. As the services leader for Workforce Management Solutions, Bill is focused on strategies and initiatives that help health systems use the data they have to achieve the outcomes they need. From implementation plans that are driven by the client's desired outcomes to an optimization team that ensures clients are fully leveraging their workforce management technology, Bill's leadership has helped ensure that the entire services strategy is built upon helping health systems optimize their staff to improve the bottom line, increase staff engagement, and help caregivers deliver the best possible care to their patients. Dr. Larkin and Lorraine, I'll now turn the floor over to you.
Hi.
Good morning. Sorry.
Go ahead, Bill.
I'm sorry. So good morning, good afternoon, everybody. Thank you very much for attending today's webinar. We have worked with Becker's Healthcare to really dig deeper into the challenges that healthcare organizations face with a survey of 75 finance executives. With workforce accounting for the largest portion of operating expenses, it's no surprise that managing labor costs is an issue that's keeping healthcare executives awake at night. Next slide, Jill. With labor cost containment a top priority, it's important to understand the biggest workforce management challenges for healthcare organizations. Through our work with health systems and the survey that we did with Becker's, we have a list of the top issues that organizations struggle with. I'm guessing that one or more of these challenges looks familiar and has caused problems for you and your team. Today, we're going to learn how UPMC addressed these challenges with a focus on staff satisfaction, unit-based turnover, and overtime spend. So it is my privilege to announce, to turn it over to Dr. Larkin and to Lorraine to share with you the fabulous outcome that they've been achieving, specifically around the unit-based turnover, staff satisfaction, and overtime spend. So Jill?
Okay, thanks, Bill. First of all, I'd like to start off with it's a beautiful day in Pittsburgh, and staffing and healthcare is definitely becomes a regional or local issue very quickly. So you need to understand Pittsburgh a little bit in order to understand our scheduling system. So Pittsburgh is the #4 best place to travel in 2017. It has been known as the Steel City, but as President Obama visited us in 2016, stated that Pittsburgh is a city that has harnessed innovation to redefine itself as a center for technology, healthcare, and education. And as you can see by the last bullet there, Pittsburgh is the 3rd in the nation for millennial growth. So that does make a difference in our staffing and scheduling. UPMC itself is known for life-changing medicine. It is an integrated delivery system and finance system. We have a provider services, we have an insurance arm, we also have enterprise services, which is a commercial arm, and our international division. So it is truly an integrated delivery and finance system. We have over $14 billion in revenue, 30+ hospitals, 65,000 employees, and 3 million members in our health plan. So saying all of that, we are a large system. As you can see on this next slide, we do have an international division and an enterprise division, which I mentioned is our commercial arm. And we wanted to bring that to your attention as we move forward. So UPMC nursing workforce, we have over 15,000 nurses. We do recommend and support shared governance structures. We have both a system leadership structure as well as local shared governance. We have over 5 of our hospitals are Magnet certified. In fact, we have folks going to the Magnet conference with our newest hospital, receiving their Magnet certification. We actually presented and utilized our Centricity's self-scheduled shift select product, which is our self-scheduling system. We started that in January. Our first go live was January 2016. Now let me say, we started that way before January 2016 as far as looking for the right solution for us. We knew that self-scheduling was very important, and we knew that having a mobile app was important as well in our scheduling system. Today we have over 8,000 users live with the system and over 121 nursing units that are live. We are currently focused on inpatient nursing areas at the present time. We have embraced the use of self-scheduling, and it truly is a journey, and we've learned a lot along the way, as well as partnering with our GE colleagues. We have a relatively small team for our large project. We have an operations team and a technical team, which you can see listed there, and both Lorraine and I are part of that operations team. Our strategic plan was to face the challenges that we had as a large organization. We had some users that were still using paper and Excel spreadsheets or something that they Googled online. And we've also had some technology systems in place that were outdated, and the use of those really varied. We had interfaces that were limited, and we had no mobile app available. And we know that for our workforce to be successful in the future, we needed a mobile strategy. Our goals were to increase nurse satisfaction and staff satisfaction. So we rolled this product out not only to our nursing staff, but also to those that are in the inpatient area. So we have our unit secretaries, our patient care technicians, and other folks such as that that are using the system. We wanted to decrease our overtime spend, to decrease our turnover, as well as to decrease our manager time, both in scheduling and the time card management process. For those of you that worry about managing your time card process every Monday, we were in that same situation. So our rollout plan that have been completed to date is listed on the slide for you. We started with our 4 large urban hospitals, which we implemented the inpatient areas. And that was, again, that was January of 2016. We then followed quickly by the next implementation being the OB units and our rehab type units in those same 4 hospitals. We then went to our specialty children's hospital and then our Union Hospital, and you can see that we followed through with our community hospitals. And our last hospital that went live was UPMC Hammett, which is about 2 hours north of the city of Pittsburgh. So we are varied in our implementation across multiple areas. And you can see the number of units that have gone live in each of those rollouts. So we are doing a rolling implementation. Our implementation strategy obviously has to do with how often we schedule. So some of you may have a 4-week cycle. We decided as a health system that we would be implementing a 6-week cycle. So that 6-week scheduling cycle determines how fast we can roll out and implement across the enterprise. I'm going to now hand this over to Lorraine as the Director of Workforce Management. Lorraine?
Thanks, Jill. I'm really excited to share our outcomes with all of you on the phone today. And I'd like to start by saying that for a complex endeavor like this, outcomes are often influenced by a number of variables. But of the 3 outcomes we're talking about today, we believe that staff satisfaction has been the most influenced by our electronic scheduling. So we chose to measure staff satisfaction using the NBN Qi, or National Database of Nursing Quality Indicators. For those of you on the phone who aren't familiar with that, it is a survey that more than 2,000 hospitals across the nation and internationally use, 95% of them magnet recognized as a part of the accreditation process. It provides a myriad of information, including nursing quality indicators, patient experience, nurse engagement, and it measures job satisfaction and evaluates the practice environment. So we use specifically the RN survey with the job satisfaction scale, and the question that we specifically used to measure our outcomes was how much influence do you have over the hours or schedule that you work? And that is measured on a Likert scale of 1 to 5. So the NBN Qi results that we're going to share today are from 2012 through 2016. We're just about to start our fall 2017 survey and really are looking forward to those results and adding them to our outcomes data. So the first one, we will look at the NBN Qi scores. The first hospital we're going to look at is UPMC Presbyterian. It's our level 1 trauma, it's an academic medical center and our flagship hospital, and has 640 beds. So when you look at the results, they were making some progress, and then in 2015 dipped a little lower. We implemented Shift Select in January of 2016, and by that fall when we took the survey, they had increased by 6.3% over the previous year. So I just want to stop and just say that we've had a colleague or two say to us, well, 6.3% is really not that large of an increase. But for those of you on the phone who work with NBN Qi or other similar surveys, you know how tough it is to bump those numbers up. It's really an endeavor, so we truly do see a 6.3 increase as a great win for us. Our next hospital with the first 4 is UPMC Shadyside, and it's a partner to Presbyterian. They're about 2 or 3 miles apart. They offer 490 beds, and they are our only magnet-designated hospital among the first 4. As you can see, as a magnet hospital, they were on a steady rise with their response to this question, but they did make additional gains post-Shift Select implementation at a modest 2.3%, but again, well above the national mean. The third hospital is McGhee Women's Hospital. Obviously, it focuses on obstetrics, but they have really added a robust menu of bariatric, orthopedic, and plastic programs as well. So for those, they offer 120 adult beds, 77 NICU beds, and 90 LDRP or OB beds. And as you can see by the slide, they were also making some steady progress, but still hovering around the low 3s. And then after Shift Select, they realized the 4% gain over the previous year, which then did boost them into above the national mean. And then our fourth hospital is our UPMC Mercy. It's our faith-based Catholic facility. and they offer 290 adult beds, which does include a large burn unit, 12 NICU beds, and 24 LDRP and OB beds. And of the first 4 hospitals, they realized the largest gain at 7.2% over the previous year, and for the first time, they did reach the national mean. Okay, so then we also wanted to take a look at the scores from a broader perspective. So we compared the scores between the units using Shift Select and the units not using Shift Select. So if we just look at Presbyterian for an example and walk across, the 39 units using Shift Select, 85% of them were above the national mean. And for the 17 that aren't using Shift Select, 41% were above the national mean. And you can see that that trended through all 4 of the first hospitals. So again, this suggests that staff using an electronic scheduling system felt that they had greater influence and control over their schedule. So if we want to talk about what contributed to the outcomes, I'm going to focus a little bit more on that third bullet. So when we embarked on the journey to move to an electronic scheduling system, it seemed that discussions around electronic scheduling was focused on open shifts, filling those holes in the schedule. And we chose to equally emphasize the self-scheduling aspect with that to drive the staff satisfaction. So, you know, all units must use the self-scheduling function. There's no opt-out. We don't want to let them decide not to use it and only use it for the open shift functions. We've set very strong expectations for our managers and schedulers. They must adhere to the posting guidelines and processes. We run reports each scheduling system to make sure that those managers and schedulers have posted on time and that they posted correctly, and we reach out to them if they haven't done either, and we help them along with the process. And this also helps set the expectations for staff. You know, they know that they can go in and start selecting shifts on a particular day at 4 p.m. And so the managers and staff work together to really work this out. And one of the other expectations that we really set for staff is that they also have to participate. Not only do the managers have to post self-scheduled shifts, but they must participate, meaning they can't go, oh, just put me in for what you want, or even worse, hand a little piece of paper to say, this is what I want my schedule to be. We've also received a lot of feedback from staff, particularly the full-time and part-time staff. We allow our full-time and part-time staff to schedule first to make their selections and balance the schedule before the casual staff goes in and selects their shifts. So that was an expected process prior to Shift Select, but it has been much easier to enforce and to maintain that with the electronic scheduling system. So that has been something that we hear time and again from our full-time and part-time staff. Some other pieces about this, we also believe that some of our successes are due to enhanced training and support. We've standardized and made UPMC specific changes to the manuals. We've created screen videos for both the staff and the managers. They're housed on our intranet so that, again, everyone has really quick access to exactly what they need to be doing and can find it. Okay. All right. Oh, and just I do think it's important to mention that we are on site when staff selects their self-scheduled shifts for the first time. Even though the system is fairly intuitive, we find that that really helps the adoption by being there on site. So for the second outcome, and when we talk about overtime spend, what we're going to share with you today is our first blush. It's 1 year out for our first 4 hospitals. And we are going to be looking at a larger picture over time, but this was, again, our first blush. And I can tell you that it's not an easy metric to wrap your arms around, but we are going to share with you what we've, wrong direction, what we've discovered. There we go. Thank you. So what we measured is a percent of overtime to paid hours, and what you see in front of you is volume adjusted. So looking at these, you can see that our numbers were going in the right direction. So again, just very quickly walk you through the first from Presbyterian. We measured 1 year previous to the implementation, 4.64%. 1 year post our implementation, 4.5. So again, we did realize a decrease in the percent of overtime and looking to more. So I think a natural question is, why do we measure the percent of overtime? And when we looked at the literature for cost savings associated with, implementing electronic scheduling, there's often an emphasis on the dollar amount. And some of those are quite impressive. But we chose to measure the percent of overtime to pay dollars because it levels the playing field, so to speak, when making comparisons. So again, very quickly, if I'm looking at a system who says they saved $1 million and they're in New York City making, an average blended rate of $40 an hour, it's really hard to compare that to a hospital that's perhaps a community hospital with a blended rate of $25. So again, it levels that playing field. And just as importantly, it removes the variables over time, how many RNs versus support hours, that mix that often contributes to this. So overall, we were very pleased with our 1 year and we're looking forward to seeing what our next outcomes will show us. To talk a little about the influencing factors, the first one is the flexible workforce, and quite frankly, ours isn't really flexible at this point. 92% of our workforce is full-time or part-time. Obviously, the balance of 8% is casual. So that doesn't give us a lot of flexibility, and we are working on that as a project endeavor. Some of the regional differences in Pittsburgh, typically everyone here wants full-time, part-time. There's a little interest in that. And we also, from my years of recruiting, many of the national stage, they either work steady days, they work steady nights, and we rotate, which often, influences how much people can pick up over time. And then the obvious things such as turnover and vacancy, which are always a little bit of a moving target. The other piece that I think is important to talk about is that the software makes you stop and think before awarding overtime. So prior to shift select, Sally's running down the hall. I say, hey, Sally, can you pick up tomorrow? With no real thought to whether that's overtime or not, and no real thought to maybe there's someone else who isn't in overtime and could just as easily pick that up. So it increases the awareness, and it also gives you the information you need to make a good decision. So sometimes picking someone who is in overtime really is a better choice. Maybe it be because of skills or skill mix. But again, the software helps you make an informed decision. And then the third outcome has to do with turnover. So UPMC measures turnover from several perspectives. One is, they left UPMC. One is that they left a hospital but stayed within the system and maybe moved to another hospital to an outpatient. And the third is that they left their unit but stayed within the hospital. And the ones we're most familiar with is someone left telemetry to go to ICU. So when we looked at the RN data from this perspective, we really didn't find any data to suggest a great influence, and we weren't surprised with that. But when we looked at the turnover for the support staff, we did find a sustained and downward trend for those moving from unit to unit within the hospital. And so, we set about talking to staff and, asking what they think they thought, whether it be the managers, whether it be the staff themselves. And what rose to the top often was that many are in school, your PCTs, patient care techs, your nursing assistants, or they have some challenging life circumstances. And often what they would do is move about within their hospital to find better schedules. I may say, hey, Jill, come to my unit. I get what I want on my unit. And so they would switch back and forth, trying really hard to find that perfect schedule and that sweet spot. Well, now with the advent of shift select, it's, again, a level playing field. There's less ability for variables, and so they tend to remain on their unit because now they're all getting the same ability to self-schedule and to pick up the open shifts. So as an effect for that, we're seeing less staff churn. There's less orienting as people are coming in and out. So overall, we were really also happy with this outcome as well. So those were the 3 outcomes that we took a look at, and I'm going to turn it back over to Jill.
Thanks, Lorraine. So as I mentioned at the beginning, this has been a journey and a process that started way before our first go live. And we have learned lots of lessons along the way. Many of these you will find with any software implementation. For example, the executive support. Having good executive support is essential to implementing any new software package. And we have been very lucky here to have both nursing executive support as well as ISD executive support. So that has helped us as we've gone down the implementation plan. So the other things that I wanted to reinforce is some of the things that Lorraine stated, is that we did really focus on standardization with individualization. And what I mean by that is that you have to have standardized processes in place in order to help the system help you. So what does that mean? If everybody had different scheduling time frames, if everyone didn't select 6 weeks as their scheduling plan, then we would have variations in the system and have workarounds. So we standardize, everyone has a 6-week schedule. That's how the system is supposed to work. We also have the same start and flow time so that everyone opens at 5 p.m. on Sunday for self-scheduling. And what that means is everyone in the system has the same start time and everyone post their schedules at the same time, which allows for staff across the system to know where they can go to select their shifts, which actually is very helpful for us as an organization. However, individualization still takes place at the local level. So at the unit level, they can still determine how many off shifts that their staff need to work, how many weekends their staff need to work, and that is usually determined by their unit-based professional practice council. So they have unit-based scheduling guidelines. So that is at a local level. So that does allow for individualization. We also have some units that have groups and schedule by group. So group A would go first, group B would go second, etc. And some units that are small and don't have groups. So we allow that and the system allows us to do that. We also have 5 interfaces, and those interfaces are essential to prevent workarounds. So one of our goals, if you remember at the beginning, is to make the lives of our scheduling teams easier. So allow the managers more time to be spending with their staff versus managing a system. So the goal of this is to have the interfaces work for them. So we have 5 interfaces. We have an interface to our HR system. We have an interface to our time and attendance system, both to and from, so that's considered 2 interfaces. So we send the schedules to the time and attendance, and then time and attendance sends the hours they actually work back to Shift Select. We also have a census feed, so that as the staff are looking at determining their staffing for the next shift, they can see what their census is currently. And that is every hour, that's a census feed hourly. So we have that coming to us from our census area. So we really are working hard to make sure that the time and attendance system is working for them. We also have, from the time and attendance system, a feed to our productivity system, so that when we are looking at a staff member who is in orientation or who is going to an education program, that actually goes to the appropriate direct or indirect hours. So all of those things used to happen on little napkins or note pages, and we don't have that happening anymore. So that actually helps our staff manage this process better. We also have a long implementation strategy. So we are a very large system and we're growing by the day. And so we need to build in a upgrade process. So when we first looked at implementing this across our enterprise, we looked at an implementation plan that didn't build in upgrades. So we had to take a step back and build in upgrades into our implementation plan. So that's why you will see some variation in our timeline, and we need to continue to do that. So we need to make sure that we take upgrades in order to make sure that we have the most updated system in order to have systems that work efficiently for our staff. The other thing is that we have an operations team and an ISD team, and what we are finding is that it becomes a sweet spot into how many that you can implement and then how many can you support going forward. So it is an important thing to look at is how big your system is and the timeline that you will implement so that you can make sure that you're supporting these teams that are live as well as implementing the teams that are coming up in the future. So it is definitely a parallel track there. The last thing that I wanted to mention is that partnering with your vendor is very important. And we found that GE is very willing to partner with us, both to look at what is needed as upgrades and using our teams to help them improve their product, but also to have their engineers come on site and spend time with our staff to see, you know, what improvements need to be made to make their lives easier. And that's really important. It was actually one of the first time that the GE engineers were actually out and in the field and watching what happens to their product in real life. So that was really exciting for our team to be part of. So as we look at lessons learned, and I just highlighted a few of those, it is important to keep the lines of communication open with your teams at each of the sites. Lorraine hosts a site coordinator meeting weekly, and we communicate any updates as well as implementation plans and strategies. So as we look at next steps, the one area that we need to continue to work on that we are going to partner with our GE client, our GE vendor, is to look at more robust reporting, both internal within the product, as well as enhancing dashboarding and analytics. We think that being able to partner with GE, we can better manage the system moving forward and giving the staff and leaders better information in order to manage more closely to what they need. So as far as staffing. So as we look at this, we found that this is probably one of our areas of weakness that we need to continue to focus on, is looking at the reporting, the analytics, and getting this information to our managers and our schedulers in a timely fashion, as well as looking at performance of the system. So GE has worked with us as far as improving our performance strategy. We know we're a large system. We know we move things fast. And so they've been working very closely with us on our performance enhancements. So I'm going to hand this back over to Bill, and looking forward to some of your questions as we complete the product or the presentation.
Oh, thank you, Dr. Larkin and Lorraine, for that fantastic presentation. We will now begin today's question and answer session. Again, please submit any questions you have by typing them into your control panel in the space labeled "Enter a question for staff" and clicking send. We will try to get through as many questions as we have time for. Bill, I will hand it over to you to moderate the Q&A.
Excellent. Thank you very much. And again, so Jill and Lorraine, thank you very much for taking the time and for being part of this. We do truly appreciate that. So the first question is, do you have nurses that float between different facilities? And if so, how do you handle that?
So we very much do. You know, a lot of our hospitals are sister hospitals, so two community hospitals, St. Margaret and East, or St. Margaret and Passivant, often do share staff in an effort to be efficient. So we also, just so you know, we have hospital-based float units, and then we have something called system nursing resources, where it's, for lack of a better way to say it, an internal agency. I know that that's not the favored, but I think it helps get across what it is. So yes, we do share staff, and honestly, Shift Select has made that much easier. There are functions within the software so that you can share that staff, and it's really affected our ability to help cover shifts. Did that fully answer your question? Answer the question, Bill? Do you think?
That was a great answer, Lorraine. Thank you.
Okay.
Next question: how do you handle opening the schedule to all? Is it by day or night? Is it all at the same time or at different times? And also, do you have a weekend requirement? How do you monitor that?
So, yes, we do. So as Jill mentioned, we do scheduling in 6 weeks periods, and we do require that everyone opens on, in Sunday at 4 p.m. And just as a side note, that date and time, or that day and time, was voted or discussed and agreed upon by our system professional practice council. So when Jill mentioned that we do use shared governance, that was a result of that. That's when our nurses wanted to begin to select shifts. And also, as a nod to, again, when you start to share staff from hospital to hospital, you have to have that consistency. You can't open it at Sunday at 4 p.m. in one facility, and then they're going to work or float in another, and they open on Monday at noon. So there has to be that consistency. So yes, we do that. And then I think that second part of that question was with regard to weekend, and we do have a formal weekend program for our staff, which does have minimum requirements. And we can get reports on that to monitor it, though we are working on some reports to help us get those numbers before the schedule is balanced and posted. But yes, we do have a weekend requirement, and we are able to track that within the system. And Jill, do you want to add something to that?
Yeah, I think the question also is around, do your regular units require specific number of weekend days or weekend hours? And that is the case. So if some units may need to pick up every other weekend, other units it's every third. So that is based on their unit based council structure that determines their self-scheduling guidelines. So those requirements are based at a unit level, and the manager determines that during alignment. And as Lorraine said, we're working with GE to be better able to effectively count the number of weekends that folks are having. There is an ability to look at it, but we want to be able to automate that process a little bit better.
So do you find that this system is fair with all staff as to shifts? And then a follow-on question is, do staff have requirements when choosing their shifts?
So the follow-up is, yes, we think it's fair as to how it opens up. So large departments open up based on groups, and that allows for fairness because the groups rotate every 6 weeks. So that allows Group A to be first this time and Group B to be first the next time. So it really has leveled that playing field a little bit better. And I forget the second part of that question, Bill. What was the second part of that question?
Do staff have requirements when choosing their shifts?
Yes. So again, that's based on unit-based requirements. So it would be based on whatever's required at the unit level. So we do have, as Lorraine said, we have weekend schedules, just specifically weekend staff. We have just night staff, and we have, different kinds of full-time equivalents that are available. So each one of those is kind of managed independently. But yes, there are requirements at a unit level, and it's based by the unit-based council decides what that is.
How is skill mix taken into consideration with self-scheduling?
So, well, that actually allows us to, the scheduling system allows us to post out how many RNs we would need according to our budget and according to, census needs. And then we also are able to post out self-scheduled needs for unit secretaries and patient care attendants. So each type of provider is actually in a different pool. So for example, RNs would be able to see RN schedules, patient care techs would only be able to see patient care techs. However, if you have a patient care tech that also picks up unit secretary, it also allows them to see that as an option. So it's fairly flexible in how you build the system in order to manage it based on your organizational needs.
And if I can just add there, I think one of the great feedback we got from our managers is that the system makes it very easily counts for you the number of RNs you have and very visually helps you see when you're down 2 nurses, up 2 nurses, how you can balance and align without the old-fashioned counting on paper that we used to do for many years. So that makes that more efficient.
Excellent. So Jill, I'm going to preface this question with do not shoot the messenger. I am asking the question. How big is your scheduling team, and do they schedule for the entire organization or system?
Okay, yes, I will get even. No, I'm just kidding. So our scheduling, our team, our implementation team, we have Lorraine, Brock, and Kathy Cox are the primary implementation group from an operations standpoint. So we are a very small team, but very mighty. And I count myself as a third of a person, so I'd say 2 1/3. And we also have an ISD support that helps us with those technology needs as well. But we don't physically schedule folks, but we do the rollout. So the scheduling happens at a very local level, and that happens at the unit-based level. So the managers and the schedulers at a unit-based level actually manage it that locally.
Excellent.
And if I add one thing that we have done is that we have also empowered, so we have the manager and we have identified schedulers. So if it's a larger unit, they may have 2 or 3 schedulers, but we've also empowered all of the bedside nurses. We've given them access to have basic scheduling functions so that all of it doesn't lean on the managers or schedulers. So if I'm the night nurse in charge and someone calls off, I have the ability and I am empowered to go into the schedule, mark them off as paid time off, and then initiate one of the functions where I can reach out and send out a text to see if I can fill that shift. So it's very live, real-time, living, breathing system, and we've empowered our staff to feel. So again, when we talk about staff satisfaction and feeling like they have input, they really do because they're helping to manage that work.
It's a great example of self-scheduling and really, as you said, having the workforce empowered to make decisions on when and how they work to fit their lifestyle.
Yep.
So other than surveys, have you done any actual measurements on the staffing efficiency? For example, does the CFO know on average how much time each nurse is spending on what tasks and what percentage goes into engaging with patients?
We have done some of that work at a very local level, but so we have, first of all, we have a productivity system that measures direct and indirect work. So to some extent that answers that question, but if you take it to the next level of a quality improvement or research initiative that is looking at specifically the exact amount of time that it takes for each of those functions to occur, whether it's documentation, medication administration, education of the patient, managing schedules, etc. We have done local studies for various other initiatives related to nurse workload and time spent with the patient. So we have done some of those studies. We have not directly have done a study to address it specifically around self-scheduling. We don't believe that the time that the nurse takes to self-schedule is a large enough volume of time. In order for them to do a self-schedule, we have watched like a person just going live with us, the system, and it actually is very intuitive and does not take them very long. If you have somebody that is not tech savvy, it may take them up to 20 minutes to do their schedule for 6 weeks, but it's very quick. So managing that schedule is, from a staff perspective, is not a large commitment of time. So
you mentioned that time and attendance feeds productivity. What what productivity system do you use, and have you seen a positive impact of Shift Select on productivity results?
So our productivity system is an internal developed system that we've used for 30 years, I guess. I'm making that number up, so don't quote me on that. But it's been around for a long time, and so we're actually using that system to monitor our direct and indirect time. And so we have not seen a large variation in this. So being 1 year out, as everybody knows, when you go live with a new system, it takes 6 months to make sure that everything's going in the right places and that everybody's doing the right thing. So we've only probably been about 6 months into being able to really use that data. So we also are looking at a cost accounting system as well. So we've been looking at both of those things very closely, looking at overtime as well as orientation cost, turnover, and all of that. So we don't have all of that data to share just yet, but we're monitoring that very closely.
Are all of your facilities unionized?
No, actually we have less unionized hospitals than non-unionized hospitals. We have, oh geez, I'm counting off the top of my head. I think we have 3. Our Western Psychiatric Hospital is unionized, and we have 2 others that are unionized that I know of to date. But we just acquired a couple of other hospitals on the east coast of Pennsylvania that I am not familiar with how many of those are unionized at this point. But to date are the ones that have been in place for the last probably couple of years. We've only have 2 plus the psychiatric hospital.
And of the 10 hospitals that we've implemented in, only 1 is unionized. And it does require a little bit more exquisite planning with Shift Select and building in the interfaces to Kronos and the pay codes and whatnot. Mm-hmm. So we've only had 1 that we've implemented.
And obviously working with the union during that implementation and making sure that they're aware of the process and have them be part of that discussion before the implementation even begins.
Have you seen a positive impact on staff turnover?
Only in that third outcome that I talked about, with regard to support staff and more of the internal churn and moving. That's where we saw our wins. So far, the data hasn't shown any other areas, but again, we're looking as we get out to a year, year and a half, 2 years, we're hoping we might see something there.
So how often do you run the actual time work data back into the scheduling system?
Oh, you mean the actuals?
Yeah.
Yes, the actuals. Yep.
That comes over every night during an interface. It happens at 10 p.m. So it's daily with a potential lag if they, swipe out after 10 p.m. But it's daily. So managers can very quickly go in and see who's already potentially heading into overtime before the end of the pay period, and manage that. Again, talking about, 2 can equally pick up the shift, but I'm going to select Jill because she's not in the danger of overtime.
So how do you make self-scheduling fair to all staff when everyone might not be available when the schedule is posted?
Well, the great thing about this is that it's available online. So, if you're in Group A and you're scheduling first, you have the first 3 days to go ahead and schedule. So they can schedule at work, they can schedule at home, and, eventually we hope that the app will allow them to self-schedule as well from their phone. So really, we haven't had a lot of feedback from staff that they felt like they were unfairly unable to schedule alongside others.
So I'd like to add a little bit about that, Lorraine, is that we usually find that when you first go live that everybody wants to jump on the initial day, but they find that they have the ability to select the shifts that they need to select and manage that process over the course of a couple of days, that it doesn't have to be instantaneous. I have to be on at a certain time in order to schedule. It just provides them greater view of the schedule and ability to select easily over the course of a couple of days. So they find very quickly that they don't have to be on at 4 o'clock on Sunday in order to make their selection. They have a couple of days in order to get that done, and they're able to usually get what they need to.
So to dovetail onto that, how do you manage open shifts? What's your process for when you have potentially a call out, or you have the typical hard to fill time slots that nobody would like to fill? How do you manage that process?
Well, the first piece to it is when you schedule, and after you balance the schedule, the system helps you figure out where your holes are. So you immediately, after balancing and approving the schedule, you post out those open shifts. So, you have 6 weeks out there that staff can plan around. So being more planful is often helpful instead of always being that last minute piece to it. But then again, you can't help but have call outs and then it's last minute. So again, it's very easy. Staff get in the habit of looking to see what's available. There is an ability for staff to go out there to create a survey that if they want to work or they're interested in picking up shifts every Friday at 11 p.m., which God we all wish, they could immediately be sent an email when one of the shifts come open if there's a call out. And then again, I think I mentioned earlier the function of the text, where as a scheduler or manager, someone calls off at 3 p.m. for 7 p.m., I can immediately push out a text for anyone who's interested in that. But Jill, I think you have additional thoughts.
Yeah, so actually Lorraine does a great job teaching people how to post the self-scheduled shifts in order to manage that process even at the self-scheduled time before it gets to open shifts. So that, I'll give you an example. If you are an ICU and you have lots of people in school and they need Tuesdays and Thursdays off, then you're going to open more self-scheduled shifts on Tuesday and Thursday because you know that that's your trouble days. If you know your weekends are your trouble, you're going to open more shifts and force people more towards the time that you need to have available. So you need to really know your staffing, know your areas when you're posting out your self-scheduled shifts, and adjust how many you're posting out for different days of the week based on your internal unit. So we have some ICUs that, they don't need to worry about the weekends because that's when their staff are free because they're all going to school. We have other units that struggle with the weekends. So it really just depends on your units, or how many maternity leaves you have, or how many leave of absences you have. So you can vary your posting based on what you know is going on in your unit. So it allows for that flexibility up front.
And you're right, so this sets the stage for less people calling off less because they got what they want.
So to follow on with that question, what happens when no one signs up for an open shift? How do you fill those unwanted time slots?
The same way we always did. I mean, some of those things never change. And so, it's a great electronic system, but it doesn't necessarily always take place of that human touch, or as some managers might say, that human pleading for, please, can you come in? Again, the way you always did at some point.
Mm-hmm. So typically, what devices are your staff using to self-schedule right now? Is it desktops? Is it a mix of iPads, iPhones, the Android devices?
Right now for self-scheduling, it's primarily the desktops at work or maybe their laptops at home, primarily. And again, we can't self-schedule with the app yet, but looking forward to that.
Excellent. So the app is available with the mobile functionality, it just hasn't been deployed, correct?
Correct. So, yes.
How does self-scheduling work for your specialty areas, ICU, CCU, within the ED?
How does it work? So for the ICUs, it's just like an inpatient area. They may have more, they may put people on call, but for the most part, it's utilized just like the medical surgical units. The ED, we have not implemented ED yet. That's in our schedule to roll out in the near future, but we have not rolled those out as yet. But it will be very similar. They will just have probably more on-call or variations in schedule. But once you get the process down, it really is working with the units and determining what their needs are from a local perspective.
Unfortunately, that is all the time that we do have for today. I do want to thank Dr. Larkin, Lorraine, and Bill for your excellent presentation, and to our audience for participating today. Enjoy the rest of your day, and we look forward to having you join us for future webinars.